All right, welcome to the scan along video for the wrist and hand. For the wrist and hand, I like to start with the dorsal side of the wrist first, and then do the rest of the hand, and then flip it over onto the image of the palmar side. So for the wrist and hand, the initial positioning I like to use is a towel to try to get the wrist flat. And so if they didn't have the towel, usually what will happen is the wrist might go into like a little bit of extension. So if you position a towel kind of underneath the hand, it allows the wrist maybe to go into a little bit of flexion, and that should help you image your structures a little more easily. And then having a towel as well for some of the other images is useful as well. So the first thing we're going to find and look for is the extensor tendons, and we're going to look for a bony acoustic landmark named Lister's tubercle on the radius. And so you're going to put your probe down directly on the wrist, and you can slide the probe up and down. And what you're looking for, I like to say it's almost like a little mountaintop on the radial aspect of the distal forearm, is right here. That's Lister's tubercle. You need to find this bony acoustic landmark right here. So as you slide up, you can see we're just the radius. As we come down, the radius kind of flattens out. We can find Lister's tubercle right here. Once we find Lister's tubercle, then we can start to identify all the extensor tendons. So we're going to go first to the radial side, and there's 6 compartments here. So this is actually as soon as you come over onto the radial aspect of the wrist or towards the thumb, you're going to see this is actually the second compartment, and this is 1 and 2 tendons right there, and that's the extensor carpi radialis brevis and longus. And we can slide up the forearm and look at those tendons as they can turn into muscle, and then we can slide all the way back down the wrist as well, and we can follow those all the way from proximal to distal. So each one of these tendons, I'd recommend that you scan them, and we're looking for any kind of fluid that are surrounding them, like a tenosynovitis, or even like tendinopathy, where you can see this really nice hyperechoic appearance, and does it lose that appearance, become enlarged and a little more hypoechoic. But then we can also look at them in long axis, and we're looking for that nice fibrillar pattern of the tendons. And again, here we'd be looking for any kind of fluid around them. The second compartment, we're going to come back to it, but the kind of unique part of the wrist, again, we're going to find Lister's tubercle, is that there's 2 other compartments that go over top of the second compartment, and then we call those intersections. And so we have a proximal intersection and a distal intersection. We'll show you that in a second here. But first, I'm going to move over more towards the thumb or radial side and look for the first compartment. So here is, again, if we find Lister's tubercle, which is here, first group of tendons is the second compartment, extensor carpi radialis and brevis. And then if we keep sliding, moving the probe, we'll find 2 other tendons here and here. And this is the first compartment. This is where the adductor pollicis longus and the extensor pollicis brevis are. While you're here, you might be able to find a small kind of hypoechoic structure on top, which would be the superficial radial nerve. And so that's should be, let's see, let's go back to here, and that is this guy right on top. And you'll know that's a vessel right there, so we know it's not that one. So it should be right on top of these tendons right here. If we want to find it, we can slide up the forearm, and actually it's right here is the superficial radial nerve. So if you slide up, you should be able to how you always know nerve from tendon is the nerve is going to remain the same size no matter what and never turn into anything. And so right there is the superficial branch of the radial nerve as it comes down right there. Okay, so that's where that one is. So we're going to come back and find the second compartment here and here, and come back to Lister's tubercle, and we're going to find the third compartment, which is the extensor pollicis longus, which lies right next to Lister's tubercle. As Lister's kind of acts as like a pulley for that tendon, and so if you come distal, like what'll happen is it takes like almost a 90-degree turn and goes over top here of the second compartment, and it's right there. It's right there, and then here it goes back to a spot next to Lister's tubercle, and so we can also go proximal and watch it turn into muscle here. All right, so that's the third compartment. Fourth compartment is the extensor digitorum and indices, which lie here, and if you're easy way to kind of recognize these is just have them kind of wiggle their fingers, and we can see them move. And you can actually slide the probe all the way down the wrist and follow these tendons all the way over top of, and here's another one, where they become the hood. So the extensor hood right here, and we can follow it all the way to distal attachment in long and short axis as well. So here we're going to go back to Lister's tubercle, and so we found fourth compartment, and we're going to find the fifth compartment, which is the extensor digiti minimi, which is right here. Again, if you want to figure out which tendon that, I can toggle the probe. You can see that, and it kind of goes to anisotropy and hypoechoic there. But if you just take their finger and they just move their little pinky finger around, you can actually see that tendon kind of jump around, so to find that. And then the last compartment is the sixth compartment, which is the extensor carpi ulnaris. So here we're at the ulna, is right here, and we're going to slide our probe. Sometimes you need to move their wrist kind of all the way, so the pinky's kind of up, and as you come over top of the ulna, the extensor carpi ulnaris kind of sits in this groove. You can see where his thumb's almost straight down, and so that's the extensor carpi ulnaris, and it sits in this groove in the ulna right here. And again, we can move our probe up, and here it's turning into muscle here, and we can move the probe distal all the way to its attachment site. So we can do both of those. After we've scanned the extensor tendons, then we're going to move into the structures of the wrist. And here's where we're going to first look at the scapholunate interval. And so we're going to first come back to Lister's tubercle, right where we were, kind of like our home base for this scan. And as soon as you come distal, you want to keep the Lister's tubercle pretty close to the middle of the screen, and you're going to slide the probe down the hand, and you're going to wait for it just to drop off the radius. The lunate is really small, and if you go too fast, you're probably going to find yourself on the capitate. So as you slide the probe, we're still at the radius, you're going to see it drops off. So here we've seen the radius has dropped off, and we're looking for two bones down here. And right there they are. Watch if I slide just a little bit more, the lunate went away, and now we're at the capitate. And so, here's some connective tissue over top of it there, but we're looking for this structure right here, and you might need to turn your probe a little bit. And it looks almost like a wedge or triangle. And what we're looking for is to make sure, we're looking for this interval. Is it widening? We can take the wrist and move it into altered deviation, and I'll show you what that looks like here. But basically, I'm just taking the hand and moving it, and I put my pinky to kind of brace on the carpals a little bit to kind of stress it a little bit more. And what we're trying to do is see if we can gap those two bones. You can see as I'm stressing it, they stay pretty much the same distance away from each other. After you've scanned the scapholunate, you're going to turn your probe. You can also come more laterally and look at the lunotriquetral interval as well. And so that's just going to be, again, if we're here at Lister's, we come right off the scaphoid is here, lunate's here. And if we moved on the ulnar side off of lunate, we can find the triquetrum here between those two bones too. Here. And there we get a good image of scaphoid, lunate, triquetrum. Okay. And again, it's kind of faintly, but we're looking for kind of this slight hyperechoic connective tissue between those two bones. A lot of times, this is the area where you're going to find ganglion cysts. As people probably had, it's probably a sequela from a minor wrist injury or something to these ligaments where they fall in on an outstretched hand like this, and that's pretty common. We see that quite commonly in the wrist, and they can be painful and tender, or it can be just incidental. So after we've looked at those, we're going to take our probe and move it 90 degrees. And we're going to look at the mid-carpal row. And so proximally, or to the left of the screen, is going to be the radius. And this first big bone here kind of looks like this is the capitate, large, kind of right down the middle. And then this is a metacarpal here. So here's the capitate, and this is the lunate. So here's where you're going to look for any kind of fluid in these joints, or any ganglion cysts, or any kind of pockets of fluid, or any kind of abnormalities here. But you're looking for, and you can slide the probe. You can probably explore. I'd encourage you to look at and identify all the different carpal bones to identify if there's any fluid around them or not. But these are the probably, at least I do these on every single wrist at least. Now, for the TFCC, it's a difficult structure to scan and identify because it's tucked away in here. And so we're going to take the wrist, we're going to put it, if we can, kind of here. And you want the wrist almost a little bit deviated radially, if you can. And then we're going to take the probe, and really it's almost right over top of that extensor carpi ulnaris, which is this tendon right on top here. And from here we can start to identify structures. And so this is the ulna right here. This is the lunate, this bone, and this is the triquetrum. And in all of here we have a lot of connective tissue that looks kind of like almost isoechoic here, and looks all the same. This structure that looks like, you know, there's anisotropy here, looks hypoechoic. This is actually the area of the TFCC here, right in that structure. Okay, and you can toggle your probe to try to make it appear a little bit more. You can kind of move a little bit more to the dorsal. I find that I can get a little bit better of an image there. And you can see these are all ligaments and connective tissue in here, and then right here is the area of the TFCC. All right. The last thing we're going to image is the ulnar collateral ligament of the first MCP. And this is quite an important structure for, you know, looking for gamekeepers, looking for a Stenner lesion. And so with the hand kind of just up here, I like to have them just hold on to the towel, like you can ball it up and just have them hold on to it. And this is just if they can tolerate this position, it gives you a good area to just scan that structure. And we're going to take our probe and put it right here on that MCP. And first thing we can probably see is the adductor pollicis here. Down here is probably some ponens. And right here we're looking for, it's this small structure between these two bones. For a Stenner lesion, what happens is the ligament tears and flaps back underneath this structure, and so it won't reattach itself on its own. And so if it tears and moves underneath there, then you probably need a surgical consultation for those to put them back where they need to be. You can also stress this structure. Now, when you stress it, I would tell you most people have quite a bit of motion. And so this is just me stressing. I'm just taking my finger and kind of moving into a little bit of a stress on that structure. And so it should have like an end point where it stops. And you feel like a pretty strict end point in there. You can see we're not seeing a very well defined ligament kind of get taut, but that's okay. You're looking for other things in that same area. Is there fluid around there? Is there debris, anything like that after a potential tear? Now, after we've done that, we're going to flip the wrist over, okay? And on this side, we're going to look at the median nerve. You can look at all of the flexor tendons of the hand and the pulleys and all of those on this side as well. First thing we're going to look for is the carpal tunnel. And there's a couple easy ways to make sure you can identify the median nerve, but again, we're going to take our probe, put it directly on the wrist crease, which is, you should be able to look at the wrist and see a very well-defined crease there. Just put your probe right on top of that. And as soon as you do, you're going to find a whole lot of different tendons and structures in there. And the tricky part here, especially those just getting started, is the median nerve can look a lot like all of the tendons. And if you look at here, we can see a lot of these different tendons here, and then the median nerve right here looks pretty similar to them all. This is the median nerve here. And so sometimes you can toggle the probe a bit and look for that honeycomb appearance of the median nerve. But if you're having trouble identifying, you want to make sure you're on the median nerve, just take your probe and slide up the forearm, and the median nerve will dive deep, but it would stay basically the same side. It won't turn into a muscle, and so it's right here on the screen. And if we looked at one of the other, we were thinking, well, I think it might be, one of these guys right here. Watch what happens when we follow him up. It turns into connective tissue, flattens out, it's aponeurosis, and it's turning into muscle there as you move further up, and it kind of disappears. So make sure when you're scanning, you make sure you identify which one's the median nerve, because the way we're going to determine if someone has carpal tunnel, or at least help us with a diagnosis, is by measuring the median nerve. So you want to make sure you measure the right structure. There's a couple different measuring techniques you can do for the median nerve. You can measure it at the area of the pronator quadratus, which is this deep structure in the wrist going from medial to lateral here. There's a pronator quadratus, and so you can measure the structure here and then measure again up at the carpal, where it's in the carpal tunnel here, and determine if it's changes in size more than 2 millimeters. The other way you can do it is just follow the median nerve up and down and get a good image where you think you're looking for any kind of focal enlargement of it. But what happens in chronic mononeuropathy, as far as ultrasound goes, it'll enlarge, it'll become a little more, it'll lose that really nice connective tissue, kind of the fascicles, that honeycomb appearance. It'll lose that and kind of look a little bit more isoechoic throughout, or a little hypoechoic. And that's just because the connective tissue is changing with a chronic condition. But anyway, you want to take a measurement all around there to get a measure for the cross-sectional area, and there's several normative data and good reports you can compare that to. But you want to scan that. Here you can also, if you like, you can also take a look at the median nerve and actually look at it in long axis, which can be tricky. And the way you would do that is by putting the median nerve right underneath the middle of the screen, and there pivoting your probe. And as you pivot, you kind of want to keep it right in the middle here. And you can see it has this like different appearance than that. Like this is tendon, and this is like just a little bit different here, and that's what long axis nerves kind of look like. And here you can see it diving down as we move proximally. And see it, tendon looks like really compact fibular pattern versus these are the fascicles of the median nerve. And again, we can, and so here's the median nerve. You can even look at it kind of move when you see the difference between the muscles and the nerve the muscles kind of move around that nerve. And if we take a look and really pull the fingers back, we might be able to see a little bit of movement in the nerve, but you kind of see that interact with the rest of the muscle tissue. So that's the median nerve, and so I encourage you to image that. And if you looked at it in long axis and you had a neuropathy, you'd see kind of a focal enlargement where it's kind of a normal shape, and then it kind of has this one area where it kind of has a bolus in it. That's usually kind of like a typical way to identify it. All right, so after you've looked for that, you can also look at the rest of these tendons, but there's not a ton of stuff you're looking here down at the wrist other than the median nerve. But if you move down into the hand, here's where you can start to see a lot of different structures. And here as you move down, if we want to look at all the flexors, so here as we move down into the hammer and come down into the fingers, just make sure you kind of review your anatomy as far as where your A1, A2 pulleys are, and etc. But the easiest thing is you put it down in the kind of in the palm right before the MCP. You should be able to identify two different, and let's go to this one. Two different tendons here above and below, and that is your flexor digitorum superficialis and profundus. So superficialis is, you know that one because it should be on top, and as you move down here, we can see where this is what like a pulley looks like here. It looks kind of like a slight hypoechoic band over top of the tendon. So we kind of see these pulleys as we move down, but as we move down in short axis, what should happen is the superficialis is going to split. Here we see it splitting, and then here it's, let's go back here. We'll do that again. So here we see the two here, right above each other, 1 and 2. 1 and 2, they're like gonna smash together. This one you can see the superficialis splitting, coming out to the sides. It's pretty hard to see, and the profundus is going to move up here to the top to more superficial, and then we have the superficialis on the lateral sides and the profundus in the middle. As that continues to happen, as you continue to move down the finger, the superficialis will attach to the middle phalanx, and the profundus will go all the way to the distal phalanx here. And we can take our probe and move it from short to long axis here, so make sure you got the gel. And this is right there's profundus coming down to the distal phalanx here. And if you slide up, we can actually see a little bit of both of them, superficialis and profundus. Here as you move down further, this image on this one. when you're looking at pulleys, you can have a little swelling around the pulley, but what we should see is that the tendons are really close to the bone, and we're looking for any kind of bowstring. So as you move there, you can see I'm just moving the pinky up and down, or I'll just have them just see if they can flex their pinky. And if you can, go ahead and flex it. Yeah. So you should see it move or slide without bowstringing above the bone. It should stay real close to the bone right here, right? Real close right here. There. Good. Okay, so you could also do with the wrist hand, if someone has an acute trauma, the other thing you can do with this is actually put them in a water bath. If you have a basin of water, you can actually do a completely non-contact ultrasound and just have the probe close to the hand without touching it, and as they're submerged in water. And that can be a great way to look at very small structures in the wrist and hand. All right, but this completes the scan along for the wrist and hand. Thank you.